Okay, I'm going to go ahead and get started. I think they can hear me out there. So this is the third in a series of updates for you all on presentations at this year's conference on retroviruses and opportunistic infections. I'm going to talk about end organ complications and OIs, that data that were presented at CROI. Just before we move on to that, you all might have noticed that there's no longer paper on the seats with a little pen for you to sit on. So we have moved to electronic evaluations for our sessions, and I would really encourage you to fill out the evaluations. In order to do that, there is an email that's sent around to everyone who normally attends the conference that has a link to the evaluations. You just click on the link, you can quickly fill it out online, and it goes right to us. So it's very important for us to keep apprised of your input and to hear your thoughts about these conferences so that we can improve what we're presenting to you all. So please do go and fill out the evaluations. It also is required for us to give you CME accreditation for attending the conference. So please fill them out if you can. Because they're electronic, we have left the link up until 12 noon each day. So you have from the time the conference ends until noon to input your evaluations. So thank you, everyone. So I'm going to move right into our discussion about end organ disease and opportunistic infections. These are my financial disclosures and those of my spouse, if you're interested. None of them directly affected anything I'm presenting today. So the outline of the talk is basically what the title is. I'm going to start first with end organ complications and then move on to a couple of comments about a discussion we had a little bit after Jill's presentation last week about complications associated with integrase inhibitors, and then move on to OIs, focusing on TB, cryptococcal meningitis, pneumocystis pneumonia, and hepatitis virus infections. So first, starting off with new data on end organ disease. The first relates to the heart. So we're getting right to the heart of the matter. This was a very interesting presentation looking at the risk of myocardial infarction in people living with HIV who have chronic obstructive pulmonary disease, asthma, emphysema, COPD, of other etiology. As by way of background, previous studies in people without HIV infection have suggested that there is an association between COPD, particularly poorly controlled COPD, and increases in subclinical markers of cardiovascular disease and incident myocardial infarction. The mechanism for that risk or association has not been fully elucidated, but I'll talk about that in a moment. In people living with HIV infection, this association has not been fully explored, although there is one study that suggested people who had more severe emphysema on chest CT, people living with HIV, had higher coronary artery calcification scores. And as you know, those scores are associated with cardiovascular disease, but it didn't explore a direct link with myocardial infarction. There also, by way of background, there are two types of myocardial infarctions that we see in people living with HIV. There's the traditional atherosclerotic kind associated with plaque formation and plaque thrombus and rupture. And there's the secondary type, or type 2 myocardial infarction, which can be of one of two types, either vasospasm or supply and demand mismatch in terms of coronary artery blood supply. And these are the type 2 MIs are generally associated with things like sepsis, where you get hypotension, reduced blood flow to coronary arteries, bacteremia that may be associated with the same thing, recent cocaine use, which can cause coronary artery vasospasm, and other secondary issues that lead to a decrease in blood supply to coronary arteries. These types of MIs are more likely in people living with HIV of younger age, and there has been association with lower CD4 cell counts, with lipid levels that are elevated and other Framingham risk scores as well. So by way of background, the investigators from the CENIX cohort studies looked at more than 22,000 people living with HIV from 5 CENIX clinics, one of which is here at UCSD, and evaluated patients with a diagnosis of COPD based on electronic health record algorithms that included many of the history and physical exam findings that go into COPD diagnoses. They also required the presence of prescriptions being filled for at least 90 days of short or long-acting COPD-associated medications and ICD codes for diagnoses that were associated with COPD. This algorithm was validated by spirometry in a subset of individuals, so objective evidence of COPD. The median duration of follow-up from the index date of this analysis to the end of the follow-up period that they investigated was about 6 years. And from a COPD diagnosis to acute incident MI was 3.44 years in the study. And there were 704 myocardial infarction events in the cohort. About 55% of these were type 1 traditional atherosclerotic myocardial infarctions, and 45% were type 2 myocardial infarctions, with about 2/3 of those occurring in the absence of evidence of sepsis, so suggesting that it was related to perhaps drug abuse, and about 1/3 of the type 2 events were associated with sepsis. And then when you look at the associations itself, there was a 2 to 2.5-fold increased risk of both type 1 and type 2 myocardial infarctions, independent of smoking background in people living with HIV who had underlying COPD. If you look at the detail in the slide, it's all going in the same direction, from unadjusted to adjusted with smoking, and then adjusted based on pack years of smoking, all of which continue to show the same association and increased risk of myocardial infarction, both type 1 and type 2, with a slightly higher risk of type 2. The authors postulated that there were probably multiple mechanisms involved in this, but COPD severity and inadequate disease control they attempted to look at in this study based on refills of COPD controlling medications and hospitalizations and clinic visits for failure of the COPD therapy, but weren't really able to get enough data from the electronic health records to make that association. There were other data that they looked at about recurrent pneumonia and other risk factors for type 1 and type 2, but insufficient information in the electronic health records was captured to really include that in a detailed way in the analysis. The next study also focuses on the heart, kind of an interesting premise, but trying to get at why people with living with HIV still have an increased risk of cardiovascular disease events despite viral suppression on adequate antiretroviral therapy. Yes.
That's what reminded me of what didn't hear. What were the viral loads on the last? Sorry, what were the viral loads in the last group? Were they all suppressed?
About 80% were suppressed, but they didn't really comment on the association with viral loads. So, yeah, missing piece of information.
It was found non-significant. That's why they didn't include it in the analysis.
That may be. They did control for an awful lot of other factors, and I didn't put them in there because they weren't significant, but I don't recall seeing specifically viral load. So going back to this presentation, an interesting premise that perhaps viral persistence in the latent reservoir may be contributing to background inflammation that leads to the increased risk of atherosclerosis. And so they went right after the end organ events, looking at carotid intima media thickness in 152 individuals over a follow-up period about 4 years with serial IMT measurements over that period of time. And they then correlated those measurements with mortality, with incident plaque events, and in coronary arteries, and levels of cell-associated HIV RNA, which is a measure of reservoir size, and DNA, a measure of reservoir viral replication. And after adjusting for all of the demographic factors and traditional cardiovascular disease factors, they showed that cell-associated HIV RNA and DNA level increase was directly associated with incident plaque and IMT progression over time, suggesting that both reservoir size and replication activity may be contributing to this ongoing inflammation that contributes to cardiovascular disease risk despite viral suppression. So an interesting finding. So now I'm going on to bones. And another large observational cohort study, the HOPS study, which looks at clinical practices that are sponsored by the CDC in, I think there are 10 different practices around the US that are included in the HOPS cohort. There are some that have come in and out of the HOPS cohort over time. But these investigators looked at incident fractures over a period of 2000 to 2017, and then selected their analysis cohort based on participants who were involved in active or recently active HOPS sites, had at least 2 visits for HOPS evaluation during the course of their follow-up, and were observed or had data observed over the period of interest. This bottom part of the slide, you can't probably read the writing very much here, but in red are what we consider to be major osteoporotic fractures, meaning those occurring at the wrist, spine, hip and pelvis, and shoulder. These others, most commonly seen here, foot, leg, and hand, were likely traumatic fractures, whereas the major osteoporotic fractures were presumably associated with osteopenia, osteoporosis, and not primarily traumatic fractures. And what they showed is highlighted up here. Again, just looking at the circled thing, are incident fractures that occurred over the period of follow-up in this study. And you can see that you won't be able to read the number here, but you can see that there's a statistically significant increase in overall mortality hazard ratio in patients who had incident fracture, independent of these other factors or other underlying risks. So incident fracture in and of itself was associated with a higher mortality in people living with HIV. And this was about a 45% increase in all-cause mortality. And when you looked at just the people who had incident fracture, and this was about 506 patients over the HOPS cohort followed over time, and looked at characteristics closest to death in 75 of these individuals, the overall major osteoporotic fractures were had the highest association with increased mortality, about a 65% increased risk or rate, and although fractures at other sites did as well, although certainly not as high. And then independent predictors of all-cause mortality within this group of people who had incident fractures included underlying chronic renal disease, HCV co-infection, non-AIDS cancers, and underlying chronic pulmonary disease. So fracture contributing to mortality within the context of a number of other underlying comorbidities. So I think the title says it all. If you break your bones, it's not a good thing. So the next organ to look at is the cervix in women. This was also a nicely done study that was a randomized double-blind placebo-controlled trial in 180 women who had HIV and cervical high-grade squamous intraepithelial lesions, precursor lesions to cervical intraepithelial neoplasia and cervical cancer. All of the women were randomized to either receive HPV vaccine, the quadrivalent vaccine that includes the 4 DNA types of HPV associated with malignancy, or a saline placebo, and they were vaccinated at entry, weeks 4 and week 26. The premise here being that HPV vaccine may prevent recurrence of the cervical lesions after treatment. So all women had a LEAP procedure at week 4, and then were followed with colposcopic cervical biopsies and cytology with major endpoint events at week 16 and week 52 after follow-up. 97% completed vaccine and biopsy results were available. Unfortunately, almost half of these still had positive margins for high-grade lesions after their LEAP procedures. So they were at high risk for recurrence. And also, this is just the distribution of the grade of abnormality seen at the time of the LEAP procedure. This is low-grade SIL or CIN1. CIN3 would be high-grade SIL. And whether you looked at the primary endpoint of cytology or histology or just histologic lesions present at any time point, vaccine and placebo were about the same. There was no statistically significant difference in the rate of the recurrence, whether patients were vaccinated or not. So clearly this is a negative study, but I think one that had an interesting premise, and we couldn't reduce recurrence by giving vaccine. Yes, Lala.
I think that's a very important study because you may remember, Dr. Benson, that we have a prior study, the ACTG 5272 in the anal canal, that it was also a similar and stronger negative study. And the thought was because the ablation therapies in the anal canal are less efficient than in the cervix when we do LEAPs. But this clearly proves that it's not just the ablation procedure, that the immunological component of it is really ineffective.
Very good point. Yes.
Hi, I was wondering what the CD4 counts were for, median range. Just wondering if there might have been an effect in those at a higher CD4
in
count.
the analysis, there was no effect. Again, these are abbreviated slides, so I didn't put all of the factors in there. But if they weren't significant, I don't show them. So, yes.
Connie, I'm not sure I totally get the premise. These are women who already had abnormalities who are getting the vaccine subsequently, and the vaccine is supposed to have a therapeutic effect?
These were people who were treated for their cervical HSIL.
Right.
And with the premise being that by giving vaccine before and after their LEAP procedure, you could reduce the recurrence rate after LEAP.
But only 16 or 52-week follow-up after that.
Right.
So, okay.
Yeah, there's going to be longer follow-up. These are just the initial primary endpoint data. So, and then, as I said, I'm going to go back to one of the points that Jill Blumenthal made in last week's talk about integrase inhibitors and safety in pregnancy. As you are aware, there's an interim analysis of a birth defect surveillance study that has been ongoing in Botswana for some time, showing what they thought was a higher than expected rate of neural tube defects in women who were on dolutegravir at the time of conception. And so there's been a lot of discussion about this, a lot of follow-up, a lot of concern, obviously. Subsequent to those initial reports, prospective analyses of pregnancy outcomes from randomized clinical trials and from antiretroviral pregnancy registries, both in Europe and the US, have failed to identify additional neural tube defects associated with dolutegravir use during pregnancy. And just to make the point that Gigi made last week, that you need to know the background rate of neural tube defects in order to put this into context. And so neural tube defect risk is not zero. It's thought to be associated with poor dietary folate, and so it may be seen in higher rates in individuals who are malnourished or receive poor prenatal care. And the background prevalence around the world is thought to be about 0.1%, or one event per 1,000 live births in HIV uninfected individuals. Lynn Moffinson did a nice review of all of these data at CROI in a symposium that I would encourage you to look at if you want more details. But she also made the point that there have been evaluations of antiretroviral therapy effect on pregnancy for 30 years now. And despite a lot of discussion and concern about this. The only thing in all of the studies that has really been a consistent association with abnormal birth outcomes has been preterm delivery rates, which are higher in people with HIV who were exposed to antiretroviral therapy pre-conception. And although these curves are a little bit hard to interpret, the blue is any adverse outcome and the green is severe outcome, you can see that despite the different antiretroviral therapy regimens, there doesn't seem to be a really consistent increase in one regimen versus another. These were all protease inhibitors or NNRTI inhibitor-based regimens. So we don't have long-term data for women followed long enough to understand any relationship like this with integrase inhibitors as of this point in time. Yeah.
I understand that prospective data collection is ongoing for the association between, well, folate and integrase. But isn't there retrospective data on, did they collect neural tube defect data in these low-income countries on, well, just historically, because folate deficiency I would bet, hasn't changed in recent years.
Well,
so if it was an
you'd be
issue,
surprised how much when they do get prenatal care, they get folate.
but I'm just saying, if this is a folate
the background rate
deficiency,
and this is in these countries, is 0.1% or 1 per 1,000 live births.
so I guess my question is,
Yeah,
are we comfortable saying, I thought we were comfortable saying we don't know if this is related to folate deficiency. And if we
yes,
have
we're
all the
comfortable
data,
saying that it's been linked to folate deficiency, but we don't know that answer either.
but shouldn't they, I guess what I'm asking, have they recorded neural tube defect data over time in these low-income countries? Because I would think folate supplementation and deficiency hasn't probably changed a great deal. Those rates should be known.
I can fairly, with fair confidence, say, no, they haven't. There are no long-term pregnancy registries in most of these low and middle income countries, which is why the Botswana surveillance registry was started. And it looks at both non-HIV uninfected and infected pregnant women over time. So that surveillance registry is one of the attempts to look at this. But I don't recall, maybe you know this, Chuck, given your integral involvement in integrase inhibitors, whether they've established the relationship between folate deficiency or not.
Yeah, in Botswana, in the Timpano study, folate use was very uncommon as a standard.
Mm-hmm.
They measured folate levels, but only in blood, which is not an optimal way to do it, and found no significant difference between the women who were receiving antiretroviral therapy and those who were not. As you're probably going to say, the cohort completed in the end of March, and the current plan is to present the final data at the IAS meeting in Mexico City. Just off the record, I'm not aware of any additional cases, but we'll see when the final data comes out.
Yeah.
If that's true, then
the
confidence intervals will overlap. And
right. Yeah, and so this left-hand side, which doesn't display very well up here, but you can see it on the side screens, show the number of new neural tube diagnosis events that would be needed to overlap with the lower bound of the confidence intervals around the HIV uninfected population in terms of neural tube defect rates. It's a little bit hard to explain all of this, but I'll just summarize for you. If there are no new defects after 1,400 exposures, then you can say that the confidence interval overlaps with the background prevalence of neural tube defects and that there's not a significant increase related to integrase inhibitors. If there's one new defect, you would need to follow 2,000 exposures. If there were two new defects, you'd need 2,500 exposures to confidently say that there was no association with with dolutegravir antiretroviral therapy. And as Chuck just highlighted, this cohort has just completed follow-up in March and has been following more than 1,400 pregnant women, and taking these data combined with antiretroviral pregnancy registry data prospectively followed, they may be able to get to these numbers and be able to say whether they're with confidence that this is not an association with dolutegravir. And then just highlighting the point that 1 in 1,000 in the general population versus 7 in 1,000 in women with dolutegravir exposure preconception, if you took this at face value, is still a relatively low risk and doesn't argue the risk may, or the benefit may outweigh the risk in terms of antiretroviral therapy.
Well, I was just going to ask you or Chuck for a crystal ball. If there are no new cases, do you think the whatever black box or the warning will be withdrawn?
He would be able to answer that. I don't deal with the FDA.
Yeah, I feel like a drug rep here. This is
Yes, well.
So 2 points. One is that there is an analysis of outcomes when dolutegravir is now available in low-income countries for $6.25 for tenofovir, lamivudine, dolutegravir. That combination pill called TLD is $6.25 a month or $75 a year. ViiV gave up the patent so the drug could be made available in low and middle income countries. So it's very inexpensive and affordable, and the World Health Organization has endorsed its use. If you take the figures from the initial analysis and project the number of deaths of children or the number of deaths of women if they do or do not have dolutegravir, then the benefit for making dolutegravir available for everyone, including women of childbearing potential, is much greater than the benefit of withholding it to prevent a neural tube defect and baby mortality. But that's partly an economic analysis and doesn't really speak to the issues of babies being born. In terms of the warning is probably, think of efavirenz, right? Remember when efavirenz came out, and the warning was based entirely on non-human primate data. And even when we began to accumulate more and more information that efavirenz really wasn't associated with it, and now it's one of the recommended regimens, it still lingered for a really long time. So I don't think that the dolutegravir and perhaps larger integrase cautions will be removed, even if the data shows that those numbers are not different. But
Okay.
Who knows?
So we're going to put that topic to rest now until the IAS conference. So other issues related to integrase inhibitors. You may have all experienced this yourself in your practices, but people have been talking for a while about seeing substantial weight gain in people who are started on integrase inhibitor therapy. So the NA Accord, another large observational prospective cohort sponsored by the NIH, looked at 24,000 treatment-naive patients initiating antiretroviral therapy and looked at the issue of weight gain following ART initiation. You can see almost 5,000 people started an integrase inhibitor-based therapy, 7,500 a PI-based therapy, and 11,000 an NNRTI-based therapy. And to make a long story short, there was weight gain with integrase inhibitors was greater than with PIs or NNRTIs, although there's some overlap between the confidence intervals between INSTIs and PIs. And specifically with the integrase inhibitor class, there was a higher weight gain with dolutegravir than raltegravir or elvitegravir, although numbers were smaller here. And again, the confidence intervals overlapped in their analysis. So I don't think this is a reason not to use integrase inhibitors. I think it's just maybe a piece of information to relay to patients when you're talking to them about what may happen after they start therapy. There's been a lot of discussion about whether this is regression to the mean, meaning people who were underweight to begin with are healthier on therapy and then gain weight, or feel better and gain weight because they're eating more and doing more things, but it's not an explainable consequence at this point in time. There also were efforts to look at switch studies with people who were fully suppressed, virally suppressed on a current regimen and then switched to an integrase inhibitor. And I won't belabor the point with the details of each of these studies, but they both showed similar findings, that there was weight gain associated with the switch to an integrase inhibitor, and there was slightly higher rates of weight gain with dolutegravir than other integrase inhibitors. But this was, I think, an interesting study that suggested about 30% had an annualized increase in weight of greater than 3%. 16% had an annualized loss of weight, and about half of patients had no change in weight. And I would imagine if you followed this many healthy, uninfected individuals and looked at weight changes over time, you'd probably find a similar distribution. So, comment, yes?
Has anyone looked at switching from integrase to another class to see if that results in losing that weight that's gained?
I don't think so. Aren't too many people that voluntarily switch off of integrase inhibitors. So you'd have to do it with taking into account what confounding factors made them switch away from integrase inhibitors. Yes, there's a question in the back. Oh, I'm sorry, Lalo was first.
So, just to piggyback on this, our patients are living longer, and the antiretroviral therapy is going to be for a long time. It's really, I struggle what to tell our patients when the other two issues that we deal with is fatty liver disease, prediabetes and diabetes, and the independent most important significant risk factor is consistent weight gain. The only study that I'm aware of is the switch from raltegravir to an NNRTI that show improvement, but that's unrelated to the weight in fatty liver disease when the patients were switched off.
Fatty liver disease,
Yeah,
right.
so that's, I don't know really what to tell the patients.
I think there's going to be a lot more coming out of these kinds of findings, but you need to look at the weight gain itself in the context of what's going on with other things.
Has anyone included bictegravir yet?
It's too early.
Still
I think.
too early.
Bictegravir's just been out, and the randomized clinical trials don't show anything, but clinical practice is different.
I have a second question too. Did the other study talk about the amount of weight gain? I'm just curious, how much to counsel patients on to expect 5 to 10 pounds, more or less?
Yeah, you probably can't read the numbers,
I
but
see.
over a 5-year period, there was a
6
kilo
okay.
weight gain. I think these are pounds actually. 6 pound weight gain. Was it kilos? Yeah.
Oh, okay. Oh, there it is. Okay.
Ah, yes, kilos. Okay. Plus 6 kilos at year 5, 5 kilos at year 2. But 4.4 for PI and 5.1 at 5 years, and for NNRTIs 3.3 at year 2 and 4.3 at year 5. Yes.
I don't know what the age of the group was, Connie, but as you know, when people around 40, they gain about a pound a year. Yeah. So
a bunch of us who
the
are
beginning,
aging
the
over
first,
time,
the first year, you know, really is obviously quite different. But I'm wondering if you put non-HIV infected people, if that would be about the same. And
I think so. This I think actually gets to that a little bit more. If you look in our country on data just about weight gain with age, you find a pretty similar distribution in just the general population in terms of annualized weight gain with age. So after the age of 40, your metabolism doesn't work as well and you gain weight. And this is actually an astonishing number, but pretty much mirrors the background in the general population. GG. Yes, it is more than the other classes of drugs. So I consider this to be interesting data that we need to explore further, particularly, as Lalo said, in the context of whether it's associated with risk of fatty liver disease, but it's also by way of information for patients when you're talking about choices of antiretroviral therapy, kind of weighing this is one potential risk. There are other risks to weigh when you're selecting different regimens.
I don't know if this is an idea that you will take it, for example, to the ACTG, because this is what the field might need. The CTRI and the UCSD NFLD Center are the first one who did this study, which you're right, it's not just about the weight gain, but how weight is accumulated. So, and now there is this technique with this Swiss company. They do MRI morphology distributions, and they not only measure the distribution of fat visceral and non-visceral, but also muscle compartments, and more important, epicardial fat distribution in addition to fatty liver disease. And that might provide a glimpse whether really is the weight gain that matters or where you accumulate the weight.
Well, if many of you will recall, we started doing all of those analyses when we looked at fat accumulation in patients being started on protease inhibitor therapy. And the early days of PI therapy was very much associated with the consequences of fat accumulation, both viscerally and peripherally. And a lot of research has gone into the distribution of fat accumulation and the distribution of weight gain with PIs. I imagine that we thought we were over that with integrase inhibitors, but it sounds like we still need work. There's still work to do to look at this question of fat accumulation with other types of antiretroviral therapies. And so I think the story will continue to unfold. Just in that vein, this was, again, a short duration of follow-up and a smaller study, but HPTN-077, which evaluated cabotegravir, the long-acting integrase inhibitor that was the subject of the Atlas and FLAIR studies that Jill presented last week. They looked at HIV seronegative individuals enrolled in this study for PrEP. Again, similar design to Atlas and FLAIR. There was a phase of oral dosing with cabotegravir and then a switch to injectable cabotegravir, either every 12 weeks or every 8 weeks versus placebo, and then a tail phase looked at. And after about, I think this goes out to 105 weeks, they found no statistically significant change in weight overall in this HIV uninfected population. And although the dark blue is cabotegravir, the light blue is placebo, although it looks like there's more in the cabotegravir group, this was not statistically significant. Those who had a greater than 5% increase in weight were about the same in the cabotegravir and the placebo group, only about 1 kilo of weight increase in both groups. And there were no significant differences by sex, dose, age, race, ethnicity, smoking, baseline BMI, or any of the other factors, suggesting, at least initially, that cabotegravir looks pretty good in HIV uninfected individuals. So whether there's something about HIV infection that interacts in and of itself, or whether there's just no relationship with weight gain and cabotegravir remains to be established in further studies. So finally, I get to move on to OIs now that we've focused on fat. I'll try to move through this enough to give you a sense of what was presented. So as you all might be aware, tuberculosis is the single greatest cause of death in people living with HIV around the globe. Maybe not in the US, but around the rest of the world, it's the most common cause of death. And interestingly, you may not be aware of this, but just for the population as a whole, tuberculosis is the largest infectious disease cause of death globally for everybody. So there's been a gradual increase in representation of TB-related studies presented at HIV meetings, but it's an important problem worldwide. So this was a study looking at safety and pharmacokinetics of the 3-HP regimen for treatment of latent TB infection or prevention of TB. with rifapentine and isoniazid given once a week for 12 weeks, and it's referred to as 3HP. This is an alternative for 9 months of isoniazid in people living with HIV infection. There were 2 groups intensively studied in this analysis, and just by way of background, you might recall that an earlier study looking at rifapentine given with dolutegravir suggested that there was an increase in hypersensitivity reactions and hepatotoxicity with those 2 drugs together. It was a small NIH clinical center study. There were only 4 patients enrolled. They stopped that study, but it's been an area of intensive investigation in the TB world. So in 60 patients were randomized, 61 were randomized, 60 completed all 12 doses of rifapentine and isoniazid. There was 1 pregnancy at week 24. CRP as a measure of background inflammation was normal at all time points measured. And looking at the PK of rifapentine with dolutegravir, and in this study, dolutegravir was dosed twice a day while receiving rifapentine. There was an intensive PK dosing group in which patients got dolutegravir alone first, and then started 3HP, and then PK was done again after dose 3 and after dose 8. And then the second group just had sparse PK sampling with the combination of both agents. And the bottom line is viral load remained fully suppressed, and dolutegravir concentrations were within the concentrations adequate for suppression of HIV throughout the course of treatment. And only 1 patient had a blip in viral load, although that was quite a blip, but it turns out was poorly adherent and resuppressed with no evidence of mutation generation after adherence counseling. 3 additional patients had grade 2 or 3 adverse events, but unrelated to study drug dosing. And there was only 1 patient who had a flu-like illness attributed to early development of an adverse reaction to rifapentine. So these data are encouraging in the TB field to suggest that you can use dolutegravir in combination with the 3HP regimen of rifapentine and isoniazid. As you know from last year's CROI, there was an ultra-short course of daily rifapentine and isoniazid given for 4 weeks, and the dolutegravir data are currently being evaluated in the context of that regimen as well. So I think we'll have reasonable news about the ability to use dolutegravir with prevention regimens for TB. The next was a cohort that also looked at pregnant women with HIV, with and without TB disease, who received IPT exposure or not during pregnancy. Now, this also goes back to a presentation from last year's CROI that suggested women who were pregnant and exposed to isoniazid preventive therapy during pregnancy had a higher All right, so anyway, so in that context, this cohort, which is from Soweto, South Africa, so a similar population as was studied in the previous evaluation, looked at 155 women who were pregnant. 71 received IPT for a clinical indication during the course of their pregnancy, and 84 did not. And they looked at pregnancy outcomes, 1 week, 6 weeks, 6 months, and 12 months after delivery. And the bottom line here is that IPT use during pregnancy was not associated with a higher rate of poor maternal or infant outcomes. And in fact, there were higher abnormalities seen in the placebo or in the no IPT group than in the IPT group. So the only caution here, of course, is this was not a randomized study. The other one was a randomized study. So I think these data are, again, continuing to evolve. This may seem like a little wonky study to you, and I won't go into great detail about it either, but just so you're aware, there are new recommendations by WHO for treating multi-drug resistant TB. And that includes a short course regimen of 9 to 12 months. And within that context, in order to have maximized therapy, that one of the things that's recommended is high dose isoniazid. The traditional dose of isoniazid is 5 milligrams per kilogram for drug susceptible TB. The recommendation for high dose is for 10 to 15 milligrams per kilogram of isoniazid. And this is to overcome 2 resistance mutations that are associated with INH resistance in MDR-TB. High-level resistance is associated with a CAT-G gene, low-level resistance with an INH-A gene. And so in this study, the investigators looked at early bactericidal activity, meaning killing of mycobacteria, in 3 groups. Group 1 were people with INH-resistant TB who had only an INH-A mutation. Group 2 was people with INH-susceptible TB, and they got conventional INH therapy. And group 3 were people with the CAT-G mutation. That group has not been enrolled or analyzed yet, so these data are from group 1 and are looking at conventional INH at 5 milligrams per kilogram per day, 10 milligrams, or 15 milligrams per kilogram per day. Bottom line here, as you can see, is a dose-response relationship in terms of ability to kill bacteria. So this is bacterial killing. It's at the 5 milligram per kilogram per day INH dose. You can see is the lowest early bactericidal activity in drug-resistant disease. This is 10 milligrams and this is 15 milligrams, and this is what it would look like in drug-susceptible TB at the conventional dose. So the bottom line conclusion here, these are the adverse events. None were related to high-dose INH, and suggesting that this regimen up to 15 milligrams per kilogram per day could be safely used in the treatment of MDR-TB. Now, this is for people who just have the INH-A resistance mutation. So the higher level mutation, that investigation is still underway. This too, another kind of wonky PK study, but I think of enormous importance around the world, and that is the relationship between a protease inhibitor that is commonly in use in the US, and whether or not you can use that with rifampin for traditional TB treatment. Currently, in the world outside of the US, rifabutin is an expensive drug. It's not widely available, even though it's on the WHO critical list. And patients with tuberculosis don't really have access to rifabutin if they need to be on a protease inhibitor regimen. So this was taking into account that there have been a number of studies of lopinavir-ritonavir double dose in combination with rifampin to overcome that drug interaction with rifampin. And it's effective in treating TB, but it's not a very well tolerated regimen as you might imagine. Darunavir-ritonavir is better tolerated, and in an effort to look at whether we could repeat or recapitulate the same outcomes with darunavir-ritonavir, doubling the dose is the subject of this study. Again, I won't go into all of the details of the different PK points, but the dosing arms were conventional darunavir-ritonavir dose given twice daily, or a double dose given once daily in combination with dolutegravir and rifampin in 2 different doses. And this is the bottom line of that slide. The first 4 patients who were randomized had marked elevations to grade 3 or 4 of ALT rapidly, and rifampin co-administration markedly reduced darunavir concentrations regardless of the dose given, suggesting that it wasn't safe to continue with this study. The study was stopped early, and the conclusion being that double dose darunavir-ritonavir given with rifampin can't really be safely done in people with HIV infection and TB. The twice daily dosing got drug concentrations despite the rifampin that were adequate, but the toxicity overrode any ability to use that regimen in treatment of TB. So moving on to another opportunistic infection, cryptococcal meningitis. This was an interesting study taking advantage of serum samples that were stored from the COAT trial. If you'll recall, we presented here before, the COAT trial was a study of early versus deferred or delayed antiretroviral therapy initiation in people who presented with acute cryptococcal meningitis. The results of that trial demonstrated that it was safer to delay antiretroviral therapy initiation until after 5 weeks in patients with cryptococcal meningitis after they'd been started on their antifungal treatment. But they had serum samples from this study and decided, although they don't ever explain why they decided to look at this, so it's an interesting observation, but they measured CMV DNA, CMV viremia, in the serum samples from the 2 arms in this study. And as you can see, in the early ART arm, there were 58 patients who had samples. 27 of those were CMV viremic, and in the deferred ART arm, 31 had CMV viremia. And these are the Kaplan-Meier survival curves between the 2 arms for CMV negative and CMV positive. And you can see that there was a statistically significant difference in cumulative mortality in patients who had CMV viremia during the time of cryptococcal meningitis. So their conclusions being that it's bad to have CMV viremia in terms of mortality if you are being treated for cryptococcal meningitis. Yes. I can't hear you.
Okay, sorry. Was there any look at the burden of cryptococcal disease? How much fungal?
Yeah, the question is, how severe was the cryptococcal? You know, I mean, there's
that was presented in the COAT trial, and I don't remember. They didn't include that in this analysis.
I'm just wondering.
Yeah. I can tell you the overall mortality in that study was pretty high, so I would imagine most of the patients had pretty severe disease. And if I'm recalling correctly, the median CD4 count in the COAT trial was under 100 for most of those patients. So,
did you treat these patients for CMV?
So there's a different point I'm going to make about that, but they didn't comment on that in this study, but the next study did. And this was looking not so much on CMV, but on cryptococcal anagenemia. But I think the point being made here is that you may need to screen for CMV, and there are other studies showing that CMV viremia given preemptive therapy didn't alter overall mortality, but that was just CMV viremia alone. And I would think that most people, if you had somebody with active cryptococcal meningitis and significant CMV viremia, that you would treat that. So I would take that message away, even though previous studies did not show an effect on mortality. But if you've got both diseases, not a good thing. Thank you. So this study didn't look at CMV, looked at cryptococcal anagenemia, asymptomatic. But this, interestingly, again, if you remember the background we've talked about at this conference before, there is an appreciable prevalence of asymptomatic cryptococcal anagenemia in people in resource-limited settings where there's a high background prevalence of cryptococcal disease. And there's a recommendation by the WHO that if you identify cryptococcal antigen in the bloodstream of people with CD4 counts of under 100, that preemptive fluconazole therapy should be administered to prevent or reduce the risk of developing cryptococcal meningitis. So in that context, this study looked at people who had stored samples being followed in an antiretroviral therapy program and looking at virologic failure, not treatment naive individuals. And they had 1,100 patients who developed virologic failure and had stored samples with HIV RNA levels greater than 1,000 copies. 35 patients in that cohort were cryptococcal antigen positive, and they looked at meningitis-free survival and showed that meningitis-free survival was substantially reduced for people who had cryptococcal anagenemia, and also was worse if they did not get fluconazole therapy. So I think this again, making the point that if you develop asymptomatic cryptococcal anagenemia, it's a precursor to developing meningitis. Preemptive fluconazole therapy may make a difference. The numbers here are probably too small to make a case for that, but clearly showing that there was a relationship between the level of virologic failure in terms of viral load and the prevalence of cryptococcal anagenemia. So the people who had the highest viral load of greater than 100,000 had a prevalence of asymptomatic cryptococcal anagenemia of about 6%. So their suggestion here is that in people who are failing a regimen, it's probably reasonable to also do screening for cryptococcal antigen in that population if you live in these areas.
We were just wondering what if they know what the CD4 counts were.
So I do not recall seeing in this poster a distribution of CD4 counts. So I think it was mostly focused on viral load, but I have the poster and I can send it to you if you want to look at it. But I would imagine that if they were people on antiretroviral therapy, their CD4 counts could be anywhere. Yes.
Do you have any recommendation? This is a related topic, but a little bit different. You know, if you have a patient with asymptomatic cryptococcal antigenemia, do you look at the titer to decide, I'm going to tap this patient or not? Because sometimes even when the titer is lower and they have asymptomatic CNS infection, they could develop iris, and I don't think so we agree, and different providers have different clinical approach.
When to do an LP. So that question has been explored in a number of these studies looking at asymptomatic cryptococcal anagenemia. And what they have shown is that a cryptococcal antigen titer of greater than 1 to 160 is associated with rapid progression and increased rapid progression to cryptococcal meningitis and an increased mortality. Directly in response to your question, though, all of those studies, when they identified cryptococcal anagenemia, did LPs. So they didn't do the LPs based on a cryptococcal antigen titer, but they did use the titer to assess prognosis and sort of degree of confidence with which they thought the patient would benefit from preemptive fluconazole therapy. So you're teasing out some details that haven't really been addressed, but they're good questions. But in all of the analyses of this issue that I've seen, everybody identified with a positive antigen test had an LP. It was just finding it was the reason to do the LP.
The guidelines on that clinical matter? Do you foresee a change in the guidelines?
In the US?
I didn't, you know.
There's already a guideline for screening for cryptococcal antigen for people who have a CD4 count of less than 100 and giving preemptive fluconazole therapy if their LP is negative. So doing an LP if they're have anagenemia, and if the LP is negative, giving them preemptive fluconazole therapy. That's the current guideline outside of the United States. Our prevalence, this also has been looked at in the US, our prevalence of asymptomatic cryptococcal anagenemia in our HIV population has really only been evaluated in one study done by the CDC in patients that they had access to through public health departments. And we had a background prevalence of about 2% in the US, 2 to 4%, depending on what area of the country you looked at. But the study they did didn't distinguish between whether or not that was asymptomatic anagenemia in people starting antiretroviral therapy or anagenemia in people after being treated for cryptococcal meningitis. So it's a little hard to tease those data out, but either way, our background rate of cryptococcal anagenemia is about half of that seen in places in lower and middle income countries. So I don't think that we have the same urgency of fluconazole preemptive therapy. And I don't know, do you all do cryptococcal antigen screening for your patients? No. We do have in our guidelines a suggestion that that may be something to do if you think your patient may be at higher risk, and generally for people with very low CD4 counts, but you might be doing that anyway. If they have CNS symptoms, you're going to be doing NLP. So, of course, you're going to be doing it, but asymptomatic screening, no. So right now we don't have in the US a firm recommendation, just, you know, some experts might recommendation do screening. So I think it really leaves it up to you. So our background prevalence is pretty low. So it's not going to make economical sense to do that. Well, it's already 9 o'clock. It's nice to have the discussion and not just blow through the slides. So I think I'm going to stop here. There are a couple of more studies that are of interest that maybe we'll get to at a future conference. So thank you.